Dr. Kavanagh is a retired ENT from Somerset, also founder of a group called Health Watch USA. Good morning, Kevin.
Oh, good morning, Jack.
You haven't been on with us for a couple months. We missed you. We're glad you're back.
Well, thank you.
Tell us what Health Watch is about.
Well, Health Watch is a nonprofit organization whose mission is to improve healthcare transparency and also patient safety, and to do this a lot by free market principles, to have patients knowing what the costs are and what the quality is, and to make them better shoppers and consumers.
You have brought with you this morning, in the last few months, you have had with you some real A-list guests, but you've really kind of outdone yourself this morning. Tell us who you have along with you this morning.
Yeah, well, we have a AAA guest today. We have Dr. Peter Pronovost from Johns Hopkins. Dr. Pronovost is by far one of the major pioneers and leaders in patient safety. I shouldn't say many years ago, but several years ago, he described a unique process in medicine, but one which was commonplace throughout industry, and that's using checklists to determine what you're going to do in a very methodical pathway, and also to do this in a teamwork fashion, utilizing all members of the team, and everybody has equal stakes in the patient care, rather than the old system, which was more flying by the seat of your pants and hoping you didn't forget all of the vital steps. And for this, he's been not only listed repeatedly as one of the top most 50 movers in healthcare, but for 2 years in a row was named by Time magazine as one of the top 100 people in the world for any type of activity or innovation.
Wow.
So we are very, very privileged to have Dr. Pronovost on the line.
Good morning, sir.
Good morning, Jack. And Kevin, thank you. And could you please tell my daughter that you heard those accolades, because I'm not sure she acts that way.
Yeah, I had the same problem with mine. And it passes down to granddaughters, too,
right.
So it never goes away.
We very much appreciate you being with us this morning, sir.
Oh, my honor.
Tell us, first of all, Kevin, you have sort of 4 specific areas you'd like to deal with this morning. Where do we start?
Well, I think it would be good just to outline, the problem of hospital-acquired conditions, of which, infections and central lines infections that we'll talk about later are a part of. These are quite commonplace nationally. A recent OIG report found approximately 1 in 7 or 1 in 8 patients either underwent a episode of temporary harm or permanent harm, and that about 44% of those were actually preventable. And so it's trying to prevent this. And of course, medicine's very complex to do. I mean, to have any end result that's good, you have to go through hundreds and hundreds of steps that all have to be done perfectly, and everybody's unique. So it's not like punching out widgets at a factory. But there are certain things that can be done and can be standardized, and this is where Dr. Pronovost's work is so crucial.
How are we doing in this country regarding that, Doctor?
Yeah, so Jack, there are far too many people suffer preventable harms. We don't know for sure how many people die needlessly, which is a big problem in and of itself, but we know that it's probably in excess of 200,000 people a year, making it the 3rd leading cause of death. It's really quite an indictment. And we've known this and focused on it for about the past 15 years in a disciplined way. The reality, though, is the empiric evidence that harm nationally has been reduced is really, frankly, limited to some of the ICU infections work that we'll talk about later with bloodstream infections. Most of the other signals maybe have gone down a little bit, but nowhere near the attention that the scope of the problem should give. Jack, just for your audience to understand this, when we say those numbers of 200,000, what that's equivalent to is 2 747s going down every day, day after day, for 15 years now. Now, if that happened in any other industry, you look at mining where, 20 or so people died and Congress turned itself over, right? Or, any of these other events, the cars with, whether it's Toyota or GM, handfuls of people, and those deaths are important, but somehow because safety deaths happen one at a time, we seem
Oh, yeah, and that is certainly true, and it is a issue that's not only spans preventable infections, but also falls, preventable patient falls, and bed ulcers and pressure sores. And many of this times this could be related to facility staffing. Sometimes it's related to not having proper protocols in place.
Right.
But it is very hard to improve patient safety when you start to have cutbacks in finances and your healthcare system's placed under stress. And one of the nice things about the idea of having checklists or a methodology to how you're doing things to standardize this is that it doesn't require a lot of infrastructure. It really requires just buy-in from the staff. And I think that that's extremely important.
As times have gotten tighter and everybody is experiencing layoffs, is that part of it? Are hospitals understaffed?
Yeah, so Jeff, that's a great question. There was a recent report by McKinsey that shows that healthcare is unique among industries that it has negative productivity over the last 20 years. Negative productivity, despite spending enormous on information technology. And it's complicated in part that we're serving up technologies to clinicians that are clunky and clumsy and probably hurt productivity, not probably do hurt productivity, haven't had an impact on safety because they don't talk to each other. The usability is poor. I mean, what we have in healthcare with devices not talking to each other would be the equivalent of, say, Boeing's building a plane and they subcontract with 1,000 vendors, and the vendor who makes the landing gear says to Boeing, I don't want to send a signal to the cockpit to tell you if the landing gear is up or down. That's my data. And Boeing says, oh, that's okay. If you don't want to send us the data, the planes will crash, people will die, it'll be really expensive, but that's okay. I mean, of course that would never happen, but that's exactly what we have in healthcare. I'll give you an example. We spend 2 full-time nurses of their time on every unit in every hospital in America double-checking pain medicines, because it's risky when we give these medicines, they can stop your breathing. But we do a human double-check, even while in most hospitals there's an electronic signal in the infusion pump and the medical record, but those two things don't talk to each other. That we act as if the vendors own the data, not the patients owning the data. And we need to start looking at productivity, because you're absolutely right. We're cutting back on staffing, and so the strain levels and the risks are going up. But I don't believe we can cut any more staffing. What we're going to have to do is start saying, how do we leverage technology or growing productivity and improving teamwork more than just simply saying, okay, nurse or doctor, now you're going to care for 25 patients in the ICU rather than 20 because my budget's cut.
How do you do that, though? That's the big question.
Yeah, so we have a number of things. I think, as Kevin's been highlighting, a big part is we need both accurate and transparent reporting of these harms. I think part of the reason why it's not getting the attention that it is it's invisible. Some of the measurement systems are less valid than others, and we need to make sure that, given the scope of this problem, the public's aware of how often it's happening, and we're monitoring progress. 2 is there are some policy things that we can do. Hospitals implemented electronic medical records, largely driven by financial incentives from the government to provide money to do this, but they didn't require that they share data or they open up data with other devices, and they could have. So hospitals rapidly implemented these technologies, but they frankly weren't ready for prime time, and that may be okay. We're going to evolve over time, but what we need to do now is to say, okay, well, now we're going to require you that we view that the patients own the data, and we open up the data so that we could link these devices and really start getting value out of them.
Yeah, and let me just put this in a little bit different format. Yesterday we had a report out from the Commonwealth Fund that 25% of our healthcare dollar is spent on hospital administration overhead, and that's higher than any other industrialized nation. And if that was brought under control, to what other nations are doing, we would save well over $150 billion a year.
Wow, that's a lot.
And it's huge. And that's something when we come back from the break, we can talk about a little bit.
Yeah, Kevin, you're absolutely right. 25% is an enormous opportunity to do something more productive with that money.
We're back with Dr. Peter Pronovost, along with Dr. Kevin Kavanagh, and this is Dr. Pronovost. This is a short segment here, and I just want to change gears for just a few minutes here while we've got you on the phone and ask you about a couple things. Number one, there was a big story in the last couple of days about an infection that is mainly affecting children that's sweeping across the country. What, sir, can you tell us about that?
Yeah, sure. Thank you very much, Jack. There's a virus that's going around, seems to affect largely children and gives them a relatively acute respiratory illness. The evidence looks like, though, that it's relatively self-limited so that these children largely recover, and they recover without any consequences. Some have been hospitalized, but like all infection prevention, it's spread by contact, so making sure we wash our hands, and as kids go back to school, whether it's making sure they have a little alcohol gel or when they wash their hands with soap. But that's really the main things that we ought to be doing to protect our children and our families.
And, of course, I would be remiss in my duties if I didn't ask you to make a few comments, if you will, about Ebola.
Yeah, so Ebola is an enormous concern. As I'm sure you're aware, it's a virus that's spread by contact, but it has about a 50% lethality. That is, if you get it, your chances of dying are 50%. We don't have any cures or treatments for it other than supporting patients, but breathing machines and fluid resuscitation. So it's quite concerning. Many hospitals in the U.S., including my own, are planning about what are we going to do if we get patients who come to our hospitals who are either have traveled from the area in Africa where it's coming from or actually have the disease. And I suspect you could be rest assured that almost all hospitals, if not all hospitals, will have plans for what to do with treating these infections. And the main thing, Jack, is ways to protect the staff, so that if I'm caring for these patients in the ICU, I don't inadvertently infect myself or my colleagues don't become infected.
We in the media get blamed for a lot of things that we may not deserve and get credit for a lot of things that we may not deserve. I'm wondering, in your opinion, how has the media handled this whole situation? Have we pulled the alarm switch, or are we underplaying the significance of Ebola?
No, I actually think the media was quite balanced in this. I mean, it's a horrible disease. There's, a large number of deaths, well over 1,000, that are growing every day. The disease is still spreading, and it warrants attention. Now, obviously, the number of patients who have come back to the U.S. is quite small. It's still a handful, but it's something that the public is interested in and wants to know about. So I think the media has thus far been pretty balanced.
You have a comment on that, Kevin?
Yeah, I agree with that. Ebola is something that really does worry me. I think that regardless of the controversies that President Obama has had in the last several weeks, his statements on Ebola that, if they don't get this under control and the virus mutates, we could be in trouble. It is an RNA virus. It's highly mutates at a very high rate. It's become a little less lethal, which actually helps it spread. When it was 90% lethal, it would be more apt to burn out. And it's a problem. We do hope that they'll be able to come up with a vaccine. I heard that they may start producing one, but because the virus mutates, whether or not that vaccine will maintain effective, we'll just have to wait and see. But it looks like it's going in the right direction at this point.
Dr. Kevin Kavanagh with us in the studio. Dr. Peter Pronovost is on the line. Let's go to your calls now, and Jolene is first. Good morning, Jolene.
Hi, good morning. I'm calling, I'm part of a group called Failed Implanted Device Alliance, and we're working on preventable harm from implanted devices like hips and surgical mesh. We would really like to have more patient-reported outcomes that are public and non-proprietary to prevent more patient harm. But we're really working hard to get media to report on these recent trials that are federal on thousands of people lined up about failed hips and surgical mesh. And you were talking earlier about Ebola and how reasonable it seems the media has been on reporting this to the public. Why do you think we're having difficulty getting more reports on implanted medical devices and getting this kind of patient-reported outcomes to be public?
Doctor?
Well, I think it goes back to what we talked about and kind of back up a little bit on that. A huge amount of overhead right now is being spent on doing administrative things with facilities. And the hospitals and a lot of medicine is just flooded with hundreds, literally hundreds, and Dr. Pronovost could tell you about how many he's reporting this year and reporting last year of things to report. And the problem has been that I've seen is that there are many, many things that are being reported that probably have very little impact on patient safety. And then there are another huge group of things that need to be reported and that they're not. And what a lot of people want to look at are outcome measures. In other words, did I get an infection? Did my implant work? You know, am I able to walk after my total knee? Rather than a process measure, which there seems to be hundreds and hundreds of these, of this step was done right and that's reported to the government, or this step was done right. And a lot of this is not necessarily the blame of the government, because when you say government, that's this all-encompassing thing up in Washington, but they have committees that are actually made up of healthcare providers, industry consumers. A lot of this comes out of the National Quality Forum that makes up these measures and makes up what is reported. And the problem is getting valid measures such as that Jolene is talking about being up as one of the things that is reported, and getting rid of, I would think, the several hundred that are either duplicative or not much use.
Joan, thank you for your call. Dr. Provost, do you have a comment on that?
Yeah, Joan, I mean, you're spot on. This harm from devices is a big issue. I don't think it's got enough attention. We don't have adequate monitoring systems, and people like you who in your organization who have a voice to keep pushing us are really needed. I mean, there's some efforts to have uniform coding of even what devices that you have, so we could know which devices and when they fail more accurately. But you're absolutely right. The patient's voice has to be heard much stronger in this. So thanks for your work and keep pushing.
Going into the break, we were talking about something about 25% overhead. What's that about, Kevin?
Yeah, well, I mean, and I'm sure that was done in the context of we need a single payer versus a non-single payer system, but there's a lot more in overhead than billing. There's a huge amount of reporting overhead. The medical records overhead is something that I just cringe at. I remember in 2007, I was in Washington, D.C. at an ARC meeting, and they were talking about they're going to have their initiative for electronic medical records. And the thing that I stressed was, well, you'd need to have a standardized file structure for these systems so that each individual entity is working off the same data, and the provider can easily change systems. Well, of course, that didn't happen. As Dr. Pronovost said, you've got one system can't talk to the other. But even more importantly, these guys can actually hold a facility hostage. Once you've got all your data loaded on a facility, the government makes one little mandate, one little change that you need to have. They can charge you whatever you want to get that little change. Or you got to rekey in all your data into the new system, which will probably take you 5 years and $100 million. And literally, I have heard where these hospitals are spending tens of millions of dollars to get these systems installed, and it's trillions of our healthcare dollar have gone. And it's all, again, because of lack of standardization, where these guys can establish monopolies, and it was quite evident on the front end on how it was set up, that it was just going to be a cash cow for some, and medicine was going to be at a loss.
Jack, let me build on what Kevin was saying about reporting measures. So I think we at our hospital now are reporting somewhere near 300 different things, right? I mean, think of an organization trying to have 300 goals, and many of them aren't very accurate, but we have greater and greater financial penalties for those. So we have no choice but to try to perform well. But performing well is much more in if we code accurately rather than we care accurately. But because of the risks, we have to hire more and more coders to make sure we perform well on this. But we'd rather be putting people, supporting nurses at the bedside or doctors at the bedside. And I think, and obviously we have those, but some of the incentives are driving us to increase that 25% overhead. And I think we need to relook at what are all these things we're submitting and get the patient's voice in there to say, are they really giving us value?
And the patient, I don't think, feels like they have much of a voice.
No, I think you're absolutely on. They've been kind of on the outside looking in, which is the complete opposite of the way it should be. It's their lives, it's their body. They ought to be driving us. I mean, we are their servants.
Well, and I think you're right. And I think that the patient needs to have a bigger voice in the National Quality Forum, which sets up these measures. And when I talk to patients, and I was talking yesterday with Helen Haskell, she started the organization called Mothers Against Medical Error, and is quite prominent. And she was, really expressing that they would like to have a small set of outcome measures that patients can wrap their hands around, that are very meaningful and that they're understandable. There are some measures that can even be counterproductive, and you wouldn't think that. But for example, and I'll give you this, the 2-hour antibiotic that has to be given within 2 hours prior to surgery. Well, I was at a facility that was getting overwhelmed trying to administrate and track this, so it was easier for them to just give antibiotics to everybody. They didn't have to then do the decision process of who needed it and who didn't. That way they would score higher, but on the other hand, giving it to anybody put me in a situation where I had a patient going for a tonsillectomy, was 1.5 years old, had severe airway obstruction. We needed to do it in the hospital setting, but because was allergic to penicillin, was going to give the child vancomycin, which was a pretty powerful antibiotic. It could be very toxic, and it wasn't needed in a child. And it was like, it was unbelievable trying to get that workaround. And again, that all stemmed from, I think, a measure that was actually changing behavior in a way that wasn't good, rather than promoting good behavior to improve patient safety.
Dr. Pronovost, what do you say?
Yeah, I think you're absolutely right on it. I mean, all these things, what we call system changes, often do some good, but they all have unintended consequences, and we need to be mindful of those. And the unintended consequences sometimes are worse than what the problem you're trying to solve. Indeed, we see many times in patient safety that the problems we're solving today were yesterday's solutions. And we need to be, I think, wiser as we put these solutions in, to be mindful of what are the unintended consequences. And mostly that, Jack, is listening to the wisdom of our doctors and nurses, because the people on the front lines know what the issues are. We just have to make sure that we listen.
Dr. Peter Pronovost is with us on the line as we go back to the calls for him, and this is Kathy. Good morning, Kathy.
Good morning. I just wanted to thank Dr. Pronovost for joining this show today and recognize him for the incredible work that he's done on central line infections. And I'd just like to ask Dr. Pronovost if he believes that we could have the same kind of success in reducing surgical site infections by using active detection and isolation for MRSA, which is a serious staph infection for people that don't know what that means. Thank you.
Thanks for calling. I'll let you listen off the air. Go ahead, Doctor.
Sure. Thank you so much for calling and your question and your kind words. When we think about what allowed us to achieve the results we do with Bushman infection. What was key is that we broke the silos down between different agencies and organizations and roles, and we all worked together, aligned with a common measure to move the needle. And though individual efforts are important, alone they don't have that big of an impact. And we believe we learned those lessons loud and clear and can apply them to surgical site infections and to these other harms. Some of the other harms we don't have clear measures yet. We need to develop them. Others, like surgical site infections, we do have good measures, and we need to make sure that we make progress. But you know, it's interesting. When we partnered with some anthropologists, one of the things that we learned was, yes, the checklist was important, but what was as important was the stories clinicians told. You see, prior to this work, clinicians just said, oh, these infections are inevitable when you care for sick patients, and there's nothing I can do about it. And after our work, the light bulb went off, and they said, no, this is not acceptable. These infections are preventable, and I am capable of doing something about this. And as you continue on your work, we need to be mindful of how do we help change that story that I think is holding us back in the safety world from thinking harm is acceptable or inevitable to know harm is preventable, and we all could do something about it.
Couple minutes left in the show, Kevin.
Yes, and I would just like to sum up by saying I think one of the most important things that was said by Dr. Pronovost is getting nurses and doctors involved in the process.
Absolutely.
And one of the things that was quite disturbing to me was the CMS ruling that you do not have to have a doctor sitting on the hospital board. I think doctors need to have an integral part of this. And I feel that measures and quality measures following hospital quality, if those are made public, it guarantees that a physician and not an accountant will be running the hospital policy, and it will be more patient-centered. And the other thing I think will have a big impact is to not only have these measures out there for the public, but that the hospital board should use these for evaluating their CEO. Some even use it for determining CEO's pay and bonuses. To put it patient safety first as opposed to how much money or profitability this institution's making.
Well, that's a novel idea. Why don't we do that, Doctor? Dr. Pronovost?
Yeah, sure. I think a lot of hospitals are starting to do that. I know our hospital, our board rigorously reviews quality and safety data, and our executives are all compensated for by it. But Kevin, you're spot on. I mean, me as a doc shouldn't be acting as a CFO to review the finances. On the same hand, you need a physician to look at quality measures because there's science behind it, and there's training that you need to have to understand if the measures are valid and how to interpret them and how to improve. One of the messages that we say all the time is that to make progress, our board quality committee needs to start functioning with the same discipline and rigor as the board finance committee.
Well, that's
and as we do that, I think we'll head to where we need to go.
Dr. Provost, I sure do see why you command the big bucks when you speak. I just hope you don't expect it from this show.
Well, thank you very much for coming.
Checks in the mail, Doctor. Thank you so much for being with us this morning.
Sure thing. Have a great day.
You too. Thank you. Thank you, Kevin.